Atrial fibrillation. This is very common. This is a rhythm that you're going to learn to look at, and it's going to be one of those sight rhythms for you. You're going to look at it, see it, and know it right off the bat. It's classically known for its irregularity. And I remember thinking when I first learned about atrial fibrillation, how can something be irregularly irregular? That makes no sense. But actually it does. There's really no rhyme or rhythm. The R waves don't march out. There's no P waves. And it's just kind of chaotic. Because again, what's happening is you have that little atrium that's just quivering and quivering along, making clots. You actually lose your atrial kick, which can lead to some decompensation, especially in sick or older patients, especially if they have valvular disease. So instead of pushing the blood into the ventricle in a coordinated effort, it's sitting there quivering. And occasionally an impulse will go down the AV node and into the ventricles, which will squeeze. So no rhyme or rhythm, irregularly irregular, and it's very, very, very common. When I had paramedic interns, I used to have, by not even assessing the patient, not knowing anything about their history, I would just feel their radial pulse, especially if they were older. That was the real key, especially going on a lot of convalescent home calls back in the day. I'd put my hand again on the radial pulse, one of the first things you want to do when you walk into the patient's room. I would feel that irregularly irregular rhythm, and I would bet the paramedic intern that I knew what the rhythm was before they hooked him up. They thought this was really cool until they learned my secret that most people with a long history of hypertension, atrial enlargement, ETOH abuse, or valvular disease will eventually have atrial fibrillation. And they didn't think it was so cool. There's sort of this haphazard appearance to the baseline. There's not really P waves, there's no real coordinated effort going on, but it's not really flat either. So there's something going on, and that's that quivering. It's quivering along uselessly. And then there's QRS complexes, which are irregular. There's really no rhythm to that either. Causes of atrial fibrillation, I just listed a few. Hypoxia is also on that list. CHF, coronary artery disease, especially mitral or tricuspid valvular issues, and hypertension. Now, why do valvular issues cause atrial fibrillation? Well, what happens is when the blood in the atrium is trying to push through a stenotic mitral valve, so it's trying to push and it's trying to open that stiff valve, that atrium is working hard to do that. The atrium is used to having no resistance when it tries to push the blood into the ventricles. Because the ventricles are relaxed, they're ready, they're waiting to accept the blood to push out the aortic valve, and they're sitting there ready, but there's something in the way. That something in the way is that mitral valve and even the tricuspid valve. If they're stenotic, and it's more common for the mitral valve to be stenotic, the atrium's working really hard and pushing and pushing and pushing to get that blood to where it needs to go, and so it ends up like any other muscle, getting bigger and getting larger, and the atrium don't like to be big. And they definitely, if you think about it, when you're sleeping, they're still working. So if the atria were some sort of unionized workforce and they never got a break, there'd be some more problems. But they don't get a break. And so they keep pushing, and they get tired. So they get stretchy, and eventually they just give up and go into atrial fibrillation. So it makes perfect sense that valvular disease equals AFib. So next time you have a patient and you know they have valvular disease and they're elderly, put your hand on their pulse. You'll be surprised how many people are actually in AFib, and you can almost sort of predict it. It's kind of fun.